Welcome back to the Radonc Smart Review CNS Cancer series. Really glad you could join us today.
Yes, welcome. Today, we're jumping into episode 3 of our high-grade glioma series.
That's right, and the focus today is glioblastoma foundations, and specifically, the Stupp protocol.
Exactly. A really crucial topic.
In our last couple of sessions, we sort of set the stage, right? We talked about the modern diagnostics for high-grade gliomas, looked at anaplastic oligodendrogliomas.
The 1p19q co-deleted ones.
Precisely, and astrocytomas too. But today, we're tackling, well, the big one, glioblastoma, IDH-wildtype. It's the most common and honestly the toughest of these tumors.
It really is. For years, years, this diagnosis was just devastatingly grim.
Yeah, the prognosis was incredibly poor.
But then, back in 2005, this pivotal trial came along.
Yeah.
It wasn't just a small step. It was, a real paradigm shift.
It laid the groundwork for modern neuro-oncology, didn't it?
Absolutely. So today, we'll really unpack the Stupp protocol. And importantly, we need to understand why, even after almost 20 years of research trying to beat it, it's still our standard of care.
That's fascinating in itself. Okay, so to make this really practical, let's use a case, a classic scenario you're likely to see.
Good idea. Helps frame the discussion.
All right, picture this. A 64-year-old man comes in, presented with a seizure, his first one.
Okay, a common presentation.
Imaging finds a right frontal lobe mass. He undergoes a maximal safe resection.
Critical first step, getting as much tumor out as safely possible.
Exactly. And the pathology comes back. Final integrated path confirms glioblastoma, IDH-wildtype, WHO grade 4.
The classic, most aggressive type.
And the molecular workup. It shows an unmethylated MGMT promoter. We'll definitely need to dig into what that means.
Crucial piece of information, that MGMT status.
Performance-wise, he's doing well. KPS is 90, so he's ready to talk about what comes next, the adjuvant therapy.
Okay, perfect. A very typical, albeit challenging case. It sets the stage nicely for discussing the evidence.
Right. But before we dive into the Stupp trial itself, let's just make sure we're crystal clear on the terminology. It matters, especially with the WHO updates.
Absolutely essential. Precision is key here. So according to the 2021 WHO classification, a classic GBM glioblastoma needs two things.
Okay, what are they?
First, it has to be an IDH wild-type astrocytic glioma. That molecular definition is fundamental.
Right, separates it from the IDH mutant types.
Exactly. And second, under the microscope, you need to see those histologic hallmarks of high-grade malignancy. That means either microvascular proliferation,
Abnormal blood vessel growth.
or necrosis, meaning areas of dead tumor tissue. Seeing either of those confirms it's grade 4.
And that IDH wild-type piece is so critical, isn't it? Because those IDH mutant gliomas, they behave very differently.
Totally different biology, much better prognosis generally. You absolutely have to make that distinction for treatment and counseling. It changes everything.
Okay, so with that definition clear, let's get to the trial that changed the game.
Right. The single most important trial, no question, is that 2005 E03 NCIC study. Everyone just calls it the Stupp trial.
The one that established radiation plus TMZ chemotherapy as the standard?
That's the one. Before Stupp, it was usually just surgery, then radiation, and outcomes were, well, dismal. This combination was the breakthrough.
So how was the trial design? They took patients with newly diagnosed GBM.
Yep, 573 patients. They were randomized into two groups.
Group 1 got radiation alone.
Radiation alone, standard 60 gray and 30 fractions. That was the control arm, representing the previous standard.
Okay, and Group 2?
Group 2 got the same radiation, 60 gray and 30 fractions, but with temozolomide, or TMZ, given concurrently during radiation and then as adjuvant therapy afterward.
Ah, so chemotherapy during and after radiation. That was the key difference.
Precisely, that combined approach.
And the specific regimen, Stupp, how does it actually work day-to-day for a patient?
Okay, so it's got two phases. First is the concurrent phase, happening at the same time as the radiation.
Right, the 6 weeks of radiation.
During those 6 weeks, patients take TMZ orally every single day, including weekends. The dose is 75 milligrams per meter squared.
Relatively low dose, daily.
Right. The idea is radiosensitization, making the radiation work better by impairing DNA repair in the tumor cells.
Okay, so 6 weeks of daily TMZ alongside radiation. Then what?
Then there's a break, usually about 4 weeks. Lets the patient recover a bit from the initial treatment side effects, like fatigue or low blood counts.
Makes sense. And after the break?
After the break, the adjuvant phase starts. This involves 6 cycles of maintenance TMZ.
6 cycles? How often are those?
It's given for 5 days straight, every 28 days. So 5 days on, 23 days off, repeated 6 times.
And the dose is higher here.
Yes, the dose goes up in the adjuvant phase, typically 150 to 200 milligrams per meter squared for those 5 days. The goal here is to tackle any residual microscopic disease.
Got it. Concurrent daily low dose, then a break, then 6 cycles of higher dose maintenance TMZ for 5 days a month.
That's the Stupp regimen in a nutshell.
And the results. You said it was a landmark achievement.
Absolutely landmark. Look at the primary endpoint, median overall survival. With radiation alone, it was only 12.1 months.
Grim.
Right. But with the chemoradiation arm, the Stupp protocol, it improved to 14.6 months.
Okay, about 2.5 months improvement in the median, which in GBM is significant.
Hugely significant statistically and clinically. It offered real, tangible hope.
And the longer-term survival, that's often where you see the real difference.
Exactly. The 2-year overall survival numbers were striking. It went from just 10% with radiation alone.
Only 1 in 10 patients alive at 2 years.
To 27% with chemoradiation. More than double the chance of reaching that 2-year mark.
Wow, okay. That is a big difference.
And maybe even more profoundly, look at 5 years. With radiation alone, survival was practically non-existent, just 2%.
Almost unheard of.
But with the Stupp regimen, it climbed to nearly 10%, 9.8% to be exact.
So nearly 1 in 10 patients surviving 5 years. That tail on the curve you mentioned.
That's it, exactly. That tail signifies that a small but real subset of patients could achieve truly long-term survival, something unimaginable before. It changed the entire conversation.
Okay, so significant survival benefit overall. But the trial also shed light on something else crucial, right? The MGMT promoter status.
Yes, absolutely critical finding. It confirmed MGMT methylation as a powerful predictive biomarker for TMZ benefit.
Can you quickly remind us what MGMT does?
Sure. MGMT is a DNA repair enzyme. Its job is to fix the kind of damage caused by alkylating agents like TMZ. TMZ adds a methyl group to DNA, which is toxic to the cell.
So MGMT protects the cell by removing that damage.
Exactly. But if the promoter region of the MGMT gene is methylated, essentially switched off, the tumor cell can't produce the MGMT enzyme effectively.
Meaning it can't repair the TMZ damage.
Right. The tumor becomes much more vulnerable to the chemo.
So what did the Stupp trial show for patients with this MGMT methylation?
For those patients, the benefit of adding TMZ was huge. Their median overall survival jumped dramatically, from 15.3 months with radiation alone to 23.4 months with chemoradiation.
Wow, over 23 months median survival. That's a massive difference compared to the overall median of 14.6.
Massive. An 8-month improvement just within that subgroup. And their 2-year survival nearly doubled, too, from 24% to 49%. Almost half were alive at 2 years if their tumor was methylated and they got stuck.
Okay, so MGMT methylation clearly identifies the patients who get the biggest bang for the buck from TMZ.
No question.
But what about the patients without methylation, the unmethylated group, like our case patient?
Right, that's the tougher group. Since their MGMT enzyme is active, it can repair the TMZ damage more effectively, making the drug less potent.
So the benefit was smaller for them.
Much more modest, yes. Their median overall survival was around 12 months, whether they got TMZ or not. Didn't see that big jump in the median.
So why give TMZ to them at all then? That's the question patients ask.
It's a very fair question. And the key lies in looking beyond the median at the survival curves again. Even in the unmethylated group, the chemoradiation arm still had that persistent tail.
Meaning more long-term survivors.
Exactly. While the median wasn't greatly improved, the 2-year survival for unmethylated patients getting chemoradiation was 15%. Compare that to just 2% for those getting radiation alone in that same unmethylated group.
Ah, okay. So even if the average benefit is small, there's still a significantly better chance, albeit small overall, of longer-term survival with TMZ, even if you're unmethylated.
Precisely. That small but real chance of long-term benefit in the unmethylated group, plus the significant overall survival benefit seen in the entire trial population when you pool everyone together.
That's why Stupp is the standard for everyone eligible, regardless of MGMT status.
That's exactly why. The NCCN Category 1 recommendation holds for all eligible patients because, on balance, the potential benefit outweighs the risks. Even for the unmethylated group, it's still our best shot up front.
Makes perfect sense. Okay, so Stupp set the standard in 2005. But you mentioned earlier that almost everything tried since then to improve upon it has, well, failed.
It's quite remarkable. and humbling. A huge amount of research went into trying to build on Stupp.
Phew.
But subsequent large Phase 3 trials testing various additions or modifications have largely been negative.
So understanding what doesn't work is almost as important.
Absolutely critical. You need to know the history to avoid repeating mistakes or using treatments that add toxicity without benefit.
Okay, so what's the first big category of things that didn't work? You mentioned dose escalation earlier.
Right. The idea of just giving more radiation seems intuitive for cancer, doesn't it?
Yeah, hit it harder.
But for GBM, it just hasn't panned out. Early RTOG trials, like 7401, looked at a conventional boost from 60 gray up to 70 gray. No benefit. No improvement in survival or control.
Okay, so just adding more gray didn't help. What about different ways of delivering the dose, like hyperfractionation?
Also tested, RTOG 906 compared standard 60 gray to 72 gray, delivered in smaller, twice-daily fractions.
The idea being maybe better tumor kill, less normal tissue damage?
That was the hope. But again, no survival benefit. Didn't move the needle.
Wow. Even with a higher total dose, what about a really focused high dose, like an SRS boost?
Stereotactic radiosurgery boost was also investigated in RTOG 9305. They added an SRS boost to the tumor bed or residual tumor after standard chemoradiation.
And the outcome?
Same story. No improvement in overall survival, no improvement in quality of life, just added complexity and potential toxicity.
So the message regarding radiation dose is crystal clear then?
Absolutely definitive. For GBM, the standard evidence-based dose is 60 grays and 30 fractions. Going higher, through any method tested so far, conventional boost, hyperfractionation, SRS boost offers no proven survival benefit and only increases risks. Stick to 60 and 30.
Okay, message received. What's the second major strategy that failed up front? You mentioned bevacizumab or Avastin.
Right. Bevacizumab, as a VEGF inhibitor, it targets tumor blood vessel growth. There was enormous hope for it in GBM, which is so reliant on abnormal vasculature.
Seemed like a perfect target.
It did. But two huge international trials, Avalio and RTOG 0825, put it to the test, adding bevacizumab to the standard Stupp regimen.
And what did they find?
They both found the same thing. Adding bevacizumab did significantly improve progression-free survival, or PFS, by about 4 months.
Okay, so the tumors looked like they were controlled for longer on scans.
Exactly. PFS improved from around 6 months to over 10 months in Avalio, for example. That looked good initially.
But
Neither trial showed any improvement in overall survival. Median OS was identical, around 16 or 17 months, whether patients got bevacizumab or not.
so longer time until the scan showed progression, but patients didn't actually live any longer. How does that happen?
It's that concept of pseudo-response. Bevacizumab is great at fixing leaky blood vessels in the tumor. This reduces brain swelling, or edema, and makes the tumor enhance less on MRI scans.
So the scans look better.
Much better sometimes. It makes it look like the tumor is shrinking or stable for longer, hence the improved PFS. But it's not actually killing more tumor cells or stopping the underlying progression effectively enough to make people live longer.
It's masking the progression almost.
In a way, yes. It controls the radiographic signs without necessarily controlling the tumor long term. And it comes with its own side effects: hypertension, risk of bleeding, blood clots.
So the bottom line for upfront bevacizumab.
The bottom line is clear. Adding it to upfront, Stupp therapy does not improve overall survival, increases toxicity, and is not recommended outside of a clinical trial. It does have a role in recurrent disease, but that's a different discussion.
Okay, dose escalation is out, upfront bevacizumab is out. What's the third category? Immunotherapy.
Right. Immunotherapy, specifically checkpoint inhibitors. Given their success in melanoma, lung cancer, etc., hopes were sky high for GBM.
Makes sense. Unleash the immune system against the tumor.
But the Checkmate 498 trial was a major disappointment. It tested radiation plus nivolumab versus the standard Stupp protocol, specifically in unmethylated patients where maybe immunotherapy could offer more.
And the result?
Surprisingly, the Stupp protocol actually performed better. Median OS was 14.9 months with Stupp versus only 13.4 months with nivolumab plus radiation.
Wow, actually worse with the immunotherapy in that setting. Why is GBM so resistant?
It highlights that unique, immunologically cold environment of GBM we touched on. Unlike hot tumors infiltrated with T cells, GBM is often surrounded by immunosuppressive factors in cells.
So the immune system isn't really primed for the checkpoint inhibitors to work effectively.
Exactly. Current checkpoint inhibitors often rely on an existing anti-tumor immune response that they can unleash. In GBM's cold environment, that response is often weak or absent. Overcoming that remains a huge challenge.
Okay, so that's a lot of negative trials reinforcing the Stupp protocol. how do we synthesize all this for making decisions with our patients?
Well, the synthesis is actually quite straightforward thanks to all this data.
Yeah.
The overwhelming evidence confirms that the Stupp protocol 60 gray and 30 fractions with concurrent and adjuvant TMZ remains the undisputed standard of care for eligible IDH wild-type GBM patients.
It's the foundation.
It's the foundation. And we know not to deviate by escalating the radiation dose.
Right. 60 and 30 is the optimal dose.
And we know not to add bevacizumab up front because it doesn't improve survival and adds toxicity.
Got it. And current immunotherapy hasn't shown a benefit upfront either.
Correct. So knowing what not to do is just as vital. It allows you to confidently recommend the standard Stupp protocol as the best proven therapy, manage expectations, and avoid ineffective, potentially harmful interventions.
Excellent summary. Okay, let's pivot to some quick takeaways. Clinical pearls.
Right. Clinical pearls, the absolute must-remember points.
Pearl number 1.
Stupp protocol is the standard for IDH wild-type GBM. 60 gray plus concurrent and adjuvant TMZ significantly improves survival over radiation alone. It's the benchmark.
Pearl number 2.
MGMT methylation status is your critical predictive biomarker. It tells you who gets the biggest benefit from TMZ. Remember those methylated patients hitting nearly 2 years median survival?
And pearl number 3.
Know what failed. Dose escalation beyond 60 gray, upfront bevacizumab, and current checkpoint inhibitors have not shown an overall survival benefit in phase 3 trials for newly diagnosed GBM. Stick to the evidence.
Perfect. Ready for a board blitz? Let's test the application.
Let's do it. Quick cases.
Okay, case 1. 58-year-old newly diagnosed GBM, MGMT methylated. He asked about getting more aggressive radiation, maybe an SRS boost. What do you say? A, yes, 70 gray improves local control. B, yes, SRS boost improved OS in RTOG 9305. C, no, multiple trials show no survival benefit beyond 60 gray. Or D, no, but maybe add bevacizumab.
Okay, the clear answer has to be C. This directly hits those negative dose escalation trials. RTOG 7401, 9006, 93005, none showed a survival benefit for going above 60 grays, regardless of how it was delivered. A is wrong, B is contradicted by 9305, and D is wrong because upfront Bev has no OS benefit. Standard is 60 gray.
Exactly. Case 2, 62-year-old woman, IDH wild-type GBM. Read about Avastin online, asked if it should be part of her initial treatment. What's the advice? A, yes, it improves OS by 4 months. B, yes, it's standard for all newly diagnosed GBM. C, no, improves PFS but not OS and adds toxicity. Or D, no, only used for IDH mutant tumors.
Right, another common question. The answer is C. Reflects the AVAGLIO and RTOG 0225 results perfectly. It improves progression-free survival, that radiographic endpoint, of absolutely no overall survival benefit up front, and it does add toxicity. A is wrong on OS, B is wrong about it being standard up front, and D is incorrect about its use context. So C is the correct counsel.
Perfect. Last one, case 3. Patient with newly diagnosed MGMT methylated GBM receiving standard Stupp. What's the approximate expected median overall survival? A, 12 months, B, 15 months, C, 23 months, or D, 48 months.
This tests the specific Stupp subgroup data. For MGMT methylated patients getting chemo-RT, the median OS was significantly longer. The answer is C, approximately 23 months. Remember, it was 23.4 months in the trial. Much better than the unmethylated group, 12 months, or the overall population, 15 months.
Excellent. Nails down those key numbers. So reflecting on all this, it really is remarkable how Stupp has remained the standard for so long, isn't it, despite all the effort?
It truly is. It speaks volumes about the profound initial impact of that trial, but also, frankly, about the incredible biological challenges that glioblastoma presents. Trying to improve on Stupp has proven exceptionally difficult.
Yeah, that immunologically cold environment, the heterogeneity, the blood-brain barrier, it's a tough nut to crack.
Exactly. And while research is incredibly active looking at novel immunotherapies, targeted agents, oncolytic viruses, TT fields, which we'll discuss next time, none have yet managed to displace Stupp as the foundational upfront therapy in large phase 3 trials.
Which really underscores why, for an eligible patient, adhering to the Stupp protocol remains absolutely critical. It's our most effective, evidence-based starting point.
Couldn't agree more. Understanding its nuances, the MGMT implications, and why alternatives have failed is core knowledge for managing this disease.
Okay, let's summarize today's deep dive then.
Right, so today we really cemented our understanding of classic IDH wild-type glioblastoma. We defined it molecularly and histologically. We spent significant time on the landmark Stupp trial's 60-gray radiation, with concurrent and adjuvant TMZ establishing it as the standard, yielding that 14.6-month median survival overall.
We detailed the huge predictive power of MGMT methylation, identifying patients who get the most benefit from TMZ, pushing median survival towards 2 years in that group. And crucially, we reinforced Stupp's place by reviewing the major negative trials showing no benefit for dose escalation beyond 60 grays, adding upfront bevacizumab, or using initial immunotherapy.
Well put. So in our next session, we'll tackle what happens beyond Stupp eligibility or after initial treatment. We'll get into Part 4, special cases, managing elderly or frail patients, tackling recurrent disease, and digging into the role of tumor treating fields.
Sounds great. Remember, you can find complete practice oral boards and other resources over at radoncsmartlearn.com. That's pronounced radoncsmartlearn.com. And please subscribe to Radonc Smart Reviews so you don't miss our next session.
Thanks very much for tuning in.